Comparison of dinoprostone slow-release Pessary Propess with gel Prostin for induction of labor at term, a randomized trial. Introduction. This is a randomized controlled trial comparing the clinical efficacy and cost-effectiveness of dinoprostone slow-release Pessary and gel Prostin for induction of labor at term. The various agents used are dinoprostone, Prostin, and Propess. Propess is a prostaglandin E2 vaginal delivery system consisting of a non-biodegradable polymeric drug delivery device containing 10 mg of dinoprostone dispersed throughout its matrix at a rate of 0.3 mg per hour. Advantages of Propess are single application, slow release over 24 hours, less invasive, ease of administration and removal, greater dose control. Currently, comparative studies have an absence of standard outcome measures. So NICE recommends further research into different prostaglandin preparations used in IOL, emphasizing on outcome measures and cost-effectiveness analysis. This study is compare efficacy, patient satisfaction, and cost-effectiveness of Prostin and Propess. The study population is 120 women requiring IOL at term with no previous uterine surgery and no contraindication to prostaglandins. Exclusion criteria was non-vertex presentation and previous uterine scar. Each woman was randomly allocated to a Prostin or Propess in a pre-packed identical sealed envelope. This slide shows the randomization, allocation, and analysis flow. This slide shows how the Prostin and the Propess were administered in the various groups. The process of fetal monitoring is elucidated here. Other information collected is also shown as below. The primary outcome measures are efficacy, patient satisfaction, cost-effectiveness. Secondary outcome measures are maternal outcomes and fetal outcomes. Seen here, the women in both groups are similar in their demographic variables. This table shows the efficacy and maternal outcome measures. In summary, there are no significant difference in augmentation rate, operative deliveries, induction to delivery interval. As seen in these two bar charts, the authors found a greater number of vaginal examinations in the Prostin group, especially that in the preemie gravidae subgroup. Maternal complications were also similar in both groups. There were no significant differences in neonatal morbidities, as seen by the UPGAR scores at birth and at 5 minutes. This is a slide showing the cost minimization analysis, calculation of the cost of induction for both Prostin and Propess groups. Each group was calculated using the drug cost plus midwife costs, and the findings was that Propess is more cost-effective. In summary, both Propess and Prostin are equally efficacious. There was a greater number of VE performed in Prostin group, especially amongst the preemie gravidae. Therefore, Propess use leads to greater patient satisfaction. Propess is more cost-effective due to the single dose and fewer midwifery hours. Both groups show similar maternal and neonatal complications and comorbidities. The results of this current study are consistent with the previous past studies. The disadvantage of Prostin gel is the need for frequent dose repetition. An audit had revealed that doses were often not repeated every 6 hours as recommended, especially during the night shifts. The advantage of Propess is that it is a knitted polyester retrieval system allowing easy removal in case of hyperstimulation. In terms of safety, the induction with Propess has no adverse consequences on child health and development. This study measures drug efficacy by number 1, the number of vaginal deliveries within 24 hours. Number 2, induction to delivery interval. Number 3, Bishop's score change of more than or equals to 3 in 24 hours. Drug efficacy in this study was measured by the number of vaginal deliveries within 24 hours, but we must always take note that labor itself is a multifactorial process consisting of power, passage, and passenger. This study uses the induction to delivery time interval to measure the efficacy of the drugs. However, the drugs are used for induction of labor. Therefore, we suggest to measure the time to labor instead. This study uses the Bishop's score change of more than or equals to 3 in 24 hours as a measurement of the drug efficacy. The problem is, cervical consistency and position are very subjective. We propose to use the simplified Bishop's score comprising of dilatation, effacement, and station instead. In summary, the additional measurements suggested are using a simplified Bishop's score, measuring the time between first insertion to onset of labor, measuring the interval between diagnosis of labor and delivery, and setting out the analgesia requirement. In terms of randomization, we also feel that the randomization of Prostin and Propess groups were done but were inadequate. Randomization was done by a midwife in charge, not a neutral party. Randomization process was also not elucidated. We suggest that block randomization be used in such a study. This is to ensure a balance in sample size across groups over time, and it is useful in trials that have substantial dropout rates due to variability and unpredictability of patient conditions, example, in labor. In terms of blinding, there was no blinding of patients and midwives. This might result in a biased estimate of treatment effects. There was also no standardization of requirements for a VE, and this may result in an increased bias against the Prostin group. Therefore, we suggest the optimal strategy of double blinding, ensuring the adequate blinding on both the operator as well as the patients prior to induction of labor. We also suggest the changing of the outcome measurement to time to labor instead of the number of VEs. This eliminates the operator biasness that comes with using number of VEs. This study measures cost effectiveness using drug cost plus cost of total midwife hours involving VE only. Naturally, more VE would result in more cost. Our suggestion is to replace the midwife VE hours with total man hours instead. This would be more accurate and inclusive for calculating the cost effectiveness. In terms of scoring patient satisfaction, this study is unclear how patient satisfaction is judged. It is assumed that fewer VEs would mean increased patient comfort and satisfaction. Therefore, we suggest to subject both treatment groups to a satisfaction survey scoring. This will allow a quantifiable gauge for comparison and also would include multiple factors that contribute to patient satisfaction, for example, pain scores, patient evaluations, etc. Thank you for listening.